By request of the meeting organizer, this meeting is being recorded.
Thursday, January 19th for our End Disparities Learning Exchange webinar entitled Transgender Health. We have a really exciting program for you today filled with presenters from around the country who work with trans folks in a number of different ways. Without further ado, I'm going to go ahead and flip us to get started. We have a number of folks on the line today, and one of the things that we like to do to help everyone get acquainted with everyone else is just to enter a little bit of information about yourself in the chat room. I'll start, or a number of people have already started. I'll say Michael Hager, NQC, New York, End Disparities Lead. And please excuse my typos. All right, so if everyone could just enter a little bit of information about yourself, and again, it'll give us a sense of who's on today's call, and you might end up seeing a couple friends from your own communities or from conferences or other interactions over time. And while people are providing this info in the chat room, I'll go ahead and talk a little bit about some ground rules. We encourage you to actively participate and write your questions in the chat area during the presentation. We have a number of staff who are going to be reviewing the chat room and answering questions directly in the chat room, and we're going to be pulling certain themes and threads out of the chat room for discussion live. You can respond generally to anything related to the topic of transgender health, or if you have a specific question related to one of the presenters, then you can enter that directly into the chat room as well. I have muted all lines. We do that because we expect a number of people on today's webinar, and we are trying to avoid distraction. In addition, we've recorded today's webinar so that folks who are not able to join us for the entire time or can't make it are able to review the webinar later. We ask that you don't put us on hold. The jazzy on hold music would be a distraction for folks on the line now, but also for folks trying to listen in later to the recording. You can see the orange button to the right of your name. Again, everyone should be muted on entry. If you want to unmute your line to ask a question live, you can press that orange button and you'll be unmuted. Again, we ask that you remute yourself when you're done speaking so that we don't have any unwanted or unneeded distractions during today's program. If you don't see a list of names, you can put your mouse cursor over my face and you'll see a button come up that says List. If you click List, then the list of names will come up and it'll replace the thumbnail views of the people who have their cameras on. If you have your own webcam and want to participate in that way, we invite you to. It's a really great way to connect with the person and the people that you're speaking with and to get more out of today's webinar experience. And I'll go to the next slide. So at this time, I would love to introduce my director, the director of the National Quality Center, Clemens Steinbach, to provide some words of welcome for today's program. Clemens? And let me unmute you, sir. There you go.
Yeah, it's a great pleasure to be part of this call today, and I want to welcome all of you. It seems like we have a wonderful turnout. It is a very important topic that we're trying to really talk about today, and I want to just recognize the wonderful leadership that we have here on this call by the various individuals. I want to thank them for sharing their wisdom with all of us. I want to encourage you to fully participate, use the chat room, and I'm looking forward to a very productive call today. We heard a lot about excitement about this call in particular. So I'm really excited that today is our first month of a focus as part of our End Disparities campaign to look at one subpopulation that we want to focus on. So, and I think it's a very important topic that we're covering today, and I want to encourage you to fully participate, use the chat room, and thanks again, Michael, for your leadership, and I'm looking forward for a wonderful call today. Thank you.
Thanks so much, Clemens. It's a pleasure. At this time, I'd also like to introduce our HIV/AIDS Bureau Project Officer, Chep Maritime, to provide some words of welcome as well from the federal perspective. And Chep, I believe I've unmuted your line.
Okay, thank you, Michael. Can you hear me?
Yes, ma'am.
All right. Hi, Michael and everybody. Thank you so much for this opportunity. I just want to welcome everybody because we have taken so much time in planning and reviewing this this webinar for today, and we're so excited to be ready to give you this great information and have you participate and listen to this very, very important topic that's just ongoing, not only in our communities, also in the federal government. And I look forward to learning from each one of you. Welcome, and thank you so much, Michael, for putting this together.
Absolutely. And Chuck, I'm going to leave your line unmuted because I think that your insight and your views are really important, and I'd love for you to, chime in as we go through if you have any thoughts or ideas too.
Okay, thank you very much.
Of course. So moving to the next slide, and for the benefit of those of you who are just joining us now in End Disparities or watching one of our videos for the first time, the Learning Exchange is a 9-month initiative to promote the application of improvement interventions that reduce HIV-related disparities in 4 key subpopulations. And as Clemens mentioned, this is our first month where we're focusing on one of those subpopulations, which is trans folks. What we're trying to do is to develop a community of learners among the Ryan White HIV/AIDS program recipients to continue thinking about health equity and social justice in the services that we provide to improve health outcomes for all people living with HIV in the United States. We offer a number of learning opportunities, including webinars like this one. We have special focus webinars for people living with HIV called Partners in Care. The next one is next Thursday, more on that later. And we also have a number of informal discussions called office hours, and we'll cover some of that later as well in terms of office hours that are coming up in the near future. This is just one thing that NQC does. NQC has a range of services that we provide to the Ryan White HIV/AIDS program community and also its subrecipients and consumers. We have a number of free online trainings and free multi-day trainings that are available for folks to apply to. Visit nationalqualitycenter.org for more information about our programs and how End Disparities Learning Exchange fits in as an important piece of the puzzle of advancing clinical quality management and quality improvement for the Ryan White HIV/AIDS program community. So, without further ado, let's dive in and talk a little bit about the agenda. We've worked our way through the welcome and introductions, and we're about to hear transgender voices in healthcare. My colleague Judy is going to provide some information or an introduction rather to our important speakers today, and we'll hear their perspectives and stories on transgender health and some of the opportunities and challenges that we have when we're trying to ensure that all trans folks have the same outcomes as the rest of us. We'll hear about the National HIV/AIDS Strategy Transgender Health Indicator that's in development and coming out around the pike. And we'll wrap up by having resource sharing and a Q&A session where we hope to engage all of you in an important dialogue around what types of interventions and strategies you've attempted or put in place to ensure that trans folks achieve the same high-level health outcomes as the rest of your patients. So one of the goals is to walk away from today's webinar and name the ways in which the transgender community is diverse. We need to stop thinking about T as a single entity and to think about a group of people that's just as diverse as any other group of people. And we'll hear a number of ways in which the transgender community is diverse and to challenge our thinking about, transgender folks as just a single large group of people because it's multifaceted. Describe the new Transgender Health Indicator being developed. This is going to be really important for our work moving forward as we try to improve health equity. And then finally, through our discussion, we hope to raise a lot of different resources that you, the Ryan White HIV/AIDS program recipients, hospitals, health centers, health departments can employ to care for trans folks in your own settings. So without further ado, I'd like to introduce my friend and colleague, Judy Popkin. Judy's an NQC coach who's been with us for about 5 years now, and she lives in Florida and serves the Ryan White HIV/AIDS program recipients in the states of Florida and Georgia. She is a wonderful person with years of quality improvement experience beyond even HIV, and it's an honor to work with her. And Judy, at this time, I'll turn it over to you to introduce Cecilia and Tia. Oops, and I will just unmute your line. Hold on just a second. There you go.
Thank you so much, Michael. It's a pleasure for me to be here, and it's an exciting topic and one that I'm very interested in myself. So I would love to introduce Teo and thank them again for joining the opportunity to talk about transgender topics. Cecilia Chung is the Senior Strategist of Transgender Law Center. She's the co-chair of the Amsterdam-based Global Network of People Living with HIV, a member of the Global Reference Group of Positive Women, and an internationally recognized civil rights leader who advocates for HIV/AIDS awareness and care, LGBT equality, and social justice. Cecilia has been a vocal advocate for transgender women and people living with HIV. Received numerous awards for her work, including the Levi Strauss & Company Pioneer Award, the Human Rights Campaign Community Service Award, and the inaugural Cleve Jones Award from the San Francisco AIDS Foundation. As an Asian transgender woman living with HIV, she's dedicated herself to ending stigma, discrimination, and violence in all communities. And that's quite a resume. Teo is a spiritual activist, an educator, a practicing Buddhist and yogi, and an artisan who works in wood and steel, multi-talented. A blue-collar, queer-identified trans man living with AIDS, Teo's activism exists at the intersections of gender, sexuality, race, class, ability, and spirituality. He serves on the faculty and board of Off the Mat, Into the World, which is the National Advisory Board of the Transgender Law Center's Project Positively Trans. And he's a founding member of the Transforming Hearts Collective. His writing can be found in the anthology Yoga and Body Image and at the blog www.rootsgrowthetree.com. And I'd love to introduce them now. Thank you for joining us.
So I'm going to have to unmute Cecilia. Hold on just a moment. There we go. Cecilia, you are unmuted.
Okay. Hi, everyone. And thank you, Michael, for inviting us to participate in this webinar. Again, my name is Cecilia Chung. I'm the Senior Strategist at Transgender Law Center. And what I'm going to share with you a little bit is, the project that I am involved with, and the idea behind it, some data that we've collected, and then turn over to Teo. By the way, I'm also a transgender woman living with AIDS, and I tested HIV positive in 1993, and I'm around to really look at how we can do things differently. So the whole idea behind Positively Trans is to create a network of transgender, especially transgender women of color and men living with HIV to develop their own self-empower mechanism and also their own advocacy agenda. We have been working on this for the last 3 years, and in about 2 years ago, we've launched a needs assessment with the national survey, and we collected approximately 157 responses, and we analyzed the response and had some really interesting data that we have published a few reports, and we are sharing that with providers and advocates, in the community. And so I want to also share some of the principles that Positively Trans believe. We believe that transgender women and transgender men living with HIV are totally capable of forming our own network and telling our own stories and developing our own strategies in addressing the inequalities, stigma, and discrimination that drive the high rates of HIV and poor health outcomes in our community. So in some ways, HIV for us seems to be a consequence on all these unfavorable living conditions and oppressions. And of course, other health outcomes are included in that as well because of the difficulty in accessing quality health care. And so we have been really focusing on amplifying the voices of community and strengthening capacity of trans leaders who are living with HIV or at risk of HIV and identify system gaps and structural inequalities that drive, the HIV epidemic. So our priorities that we have established is, to look at how to create an enabling environment that includes protective laws, ending social exclusion, stigma, and economic marginalization, and also overcome unmet needs. So now back to the data I mentioned, 157 complete responses, and out of the 157, 84% are transgender women and 69% are people of color. And 43% of our sample making less than $12,000 a year. And the median age for our sample is around 42, and median time living with HIV is 12 years. And so in some ways, like when I share the data with you, bear in mind that these are usually folks who have had lived, like most of their adult life and have a long history of being someone living with HIV. It's most of them are not recent diagnosis, and that's where the median age time of 12 years comes in. I think that it's really important to talk a little bit more about why we decided to do this survey. We know that, like transgender women and men are everywhere, and, and so they access, care like everybody else in addition to gender-related care like hormone therapy, and sometimes we will also, access, like possibly, surgery in order to confirm our gender, such as like top surgery for trans men and breast augmentation for trans women, and sometimes, gender reassignment surgery that would include, genital reconstruction surgery. And out of the surveys, we have asked them what their health concerns are, and, the 5 priorities that they name. The priorities themselves are not surprising. What's surprising is the order of them. The number 1 priority of health concerns is gender-affirming and non-discriminatory health care, followed by hormone therapy and side effects. And the third is mental health, including trauma recovery. And number 5 on that list is antiretroviral therapy and side effects. And I want to share a quote that Theo, who's going to speak after me, who had said that, and I think that resonates with many of us very well, is that he said he'd rather not have his ARV than like to have to live another day being misgendered. And I think that really speaks to the importance of like having transition-related care. And one of our recommendations naturally is, to like explore integrating gender transition care with, HIV care. We also ask our respondents their legal priorities. The number 1 priority for the respondents are HIV-related criminalization, followed by employment discrimination, and the third, which is a hot topic today in many different states, is discrimination in public accommodations, which includes bathroom access. And out of our, I think that's really important to like point out, like some of these legal challenges, because in our respondents, 41% had reported a history of incarceration, whether it is prison, jail, or immigration detention, and we also asked, like if they have ever been refused care because whether they're trans or HIV because of HIV, 31% of the respondents said that they have been refused care because of their gender identity, and 20% of the respondents said that they had been refused care because of the HIV. And interestingly, we were talking about this earlier today also, that sometimes, in our not so distant history, that there are providers who actually would charge more in order to have gender reassignment surgery performed on transgender women who are living with HIV. But that would be a story to tell another time. And when we ask them, their legal rights and how confident they are that they know their rights, as a trans person, 44% had reported that they are mostly and completely unsure of what their rights are as transgender people. So that's almost like half of our sample reported that they are not certain, what they're entitled to. And when we ask, if they are very completely confident, in their rights, 55% said yes. And when we look at HIV discriminations, when we ask, if they know their rights as person living with HIV, 40%, that's still very high, has said that they are not certain of their rights. So how is this working in order to advance our rights, and also to really recommend culturally more competent care, as well as more considerations into what constitutes HIV care. We want to align these with also some of the national HIV strategies. So we did look at follow-up questions, which is to ask them whether they have been they have a lapse of care for over 6 months, and since the HIV diagnosis. And disturbingly, 41% had reported that they do have a lapse of healthcare, and usually, this happens more frequently amongst those who have a history of incarceration. And when we look deeper into our survey samples, those who have been discriminated also have had that experience, and that experience also becomes more noticeable when we look at the actual sample from the South. So hold on a second, I have to pull up my, my data on the South to share with you. So when we look at this same set of data and look at the same questions, like the health, the economic vulnerabilities, and, and also, their, I think that the next question touched on the indicator, so the viral load. We want to share this information with you, and hopefully, you can bring it back to your colleagues and really think about this a little bit. Is when we ask our respondents, looking at how their work experience and housing experience are, we found that, respondents from the South experience, a higher rate of housing and workplace discrimination. And as high as almost 40% of the Southern respondents have reported housing discriminations, compared to a little over 30% in the rest of the country. And the same holds true for workplace discrimination. Almost 60% of our Southern respondents have reported being discriminated in workplace, versus about 42% of the rest of the country that have experienced workplace discrimination. So that is not to say that 42% is a small number, but in the South it's more rampant. And when we ask them about their healthcare barriers, 30% of our Southern respondents says that they are uninsured, and compared to about 7% for the rest of the country. So a lot of this really also has to deal with two things, which is whether the state have Affordable Care Act and also Medicaid expansions. And so if they do, they would be counted as insured, not as uninsured. And so we're still seeing 30% of uninsured, in the South. And when we ask them about the attitude of doctor for HIV care, about 31% from the South says that they experience hostile or hostile providers versus about 14% from the rest of the country. When we look at, the difficulty for them accessing hormones, over 50%, it's about 52% from the South had report difficulty accessing hormones, from a clinic or health providers. So that ends up like some of the solutions, like community comes up with is black market hormones, and sometimes, silicone injections, which we also call silicone pumping, becomes very prevalent, high prevalence. So how does that relate to my last point that I was trying to make, which is viral load? I think that we're going to touch on that today, right, Michael?
Absolutely.
About that. What we know from looking at the sample is that among those who are in the South, only 71% have was able to have undetectable viral load, compared to 81% of the respondents across the country. What's more important among this is out of those who are in the South without insurance, we're looking at 30% of those who are, we're looking at about a little over 30% of them who have no insurance, who are uninsured, that have had both a history of not getting health care, a lapse of health care more than 6 months, and as well as, was not able to achieve a detectable viral load. And within our sample, 8% actually of the South that actually say that they've never had a viral load test done. So I'm going to try to end there and, and give Theo more time to really talk about one of the experience, that within the community we often overlook, which is, transgender men living with HIV. When Michael first invited us to be part of this, I thought that, this would be a good opportunity to really, share with you all some of the challenges and how resourceful, the trans men communities, especially trans men living with HIV, the communities are trying to create a support system for one another. So with that, I'm going to turn this over to Theo. Thank you.
Absolutely. And real quick, first, there's just a couple of threads within the chat room that I want to kind of pull out for us to chew on. I don't think that we necessarily need to answer the questions just yet, but just to kind of continue thinking about this as Theo is speaking. One, folks are excited to see your data that we can share with them after today's webinar. And one thing with that, Cecilia, is it possible to share the survey as well? Because there's a number of folks who are interested in learning more about that survey.
We have published 3 reports so far, and
Beautiful.
They are all accessible on our website, transgenderlawcenter.org. But I also will forward them to NQC so that it would be in the resource bank.
Thank you so much. And here's an image from some of the resources that are available in the Transgender Law Center. There are a number of stories that you can watch at your leisure to get a sense of trans folks' own journeys regarding HIV and health and health equity. So, you know, Cecilia, one other thread that had come out, and I just want folks to think about this in case we missed it in the chat room, is the issue of trust. Thinking about how we can make sure that trans folks are meaningfully involved in helping to steer quality and clinical process within our settings. You know, invitations are sent out, but then folks, the sense is that there's not enough trust for folks to want to come and join the table. So what types of solutions do we have to help build that trust and to help bridge those gaps?
So, and I think that, you know, number one, you know, to build trust, we have to talk about intention. So if there is the intention to really provide the support and meaningfully include transgender, either transgender men, transgender women, or, you know, both transgender men and women in program design, policy, or create a more trans welcoming space, we would really encourage you to think about not having, you know, a shared space to begin with, but to make it very trans-specific so that, you know, communities will feel more comfortable, you know, to speak on different issues and respond to different questions. And also, you know, in most of the Ryan White programs, you know, like there are many opportunities, you know, like for the community to step up, you know, and become part of the workforce. And so if there is a transgender program, we, of course, you know, like encourage, you know, like providers and organizations to hire transgender people into those positions. And what I mean by those positions, I didn't just mean frontline positions as peer navigator or peer advocates, but to really allow them to also have different positions like supervisors, managers, or even higher, to really cultivate and nurture those leadership is quite important as well. You know, when you look at how big of a percentage of our community actually experiencing, you know, workplace discriminations and also make less than $12,000 a year, there's more reason to really help to look at economic justice as one of the principles in this work.
Super fabulous. Thank you so much for that answer. And for everyone else on the line, continue thinking about this as we hear Tio and Nala and Milo speak. John, Alicia, Dawn, and Dolores, we'll certainly circle back to make sure that we've answered your questions by the time today's webinar is completed. Let me scroll down and unmute Tio. Here, you're unmuted.
All right. Thank you for this, and definitely thank you. It's nice to see the engagement and people asking questions. You know, and I think one of the important things to understand is that, you know, like Cecilia often says, is our data, you know, without narrative and without sort of heart and soul, you know, falls flat. And certainly narrative without data, no one believes us, right? Like it's easy to dismiss my story as either my own individual creation or just sort of an anomaly. And when you start to pair narrative and data, it's really powerful. I was diagnosed with HIV in 1995. And when I was diagnosed, I was prior to gender transitions. So the rest of the world was interacting with me as if I had been born a girl and was intending to stay that way. And so when I was diagnosed, as somebody who was gender nonconforming, I was about as butch as a human being could be without acquiring facial hair that I have now. And so the world was interacting with me in a very particular way. And in the early 90s, what I was told over and over again was that, that certainly that dykes and queer women were not at risk for HIV. And so I actually had to fight to get tested. I was partnered with somebody who was HIV positive. And still, I was partnered with somebody who was HIV positive. I was having multiple symptoms of random stuff like hand, foot, and mouth disease. I had 5 childhood illnesses in my 20s, all in a row. And still, I had to actually argue with somebody and refuse to leave, until someone drew my blood. And from that experience, it sort of formed my relationship, particularly at that point, as somebody who is gender nonconforming and as somebody who has since transitioned. With HIV care, which was that at every step of the way, I've had to prove that I'm actually real, and the burden of proof has been on me. And when providers have been called up short, like when my reality was different than their expectations, I've had to bear the brunt of their disapproval, right, and their shame and their lack of preparedness, right? Like it's been put at my door, and that has happened over and over again. And so, I was diagnosed in 1995, and like Cecilia said, like I'm very clear that I was put on a collision course with HIV because of the societal oppression that I was living under, right? Like that the sort of level of shame and the sort of level of lack of autonomy, the level of sort of relational violence and addiction, that I got sober at age 23, and it still took me, a long time to sort of crawl out of that hole. But all of those pieces of not seeing myself reflected in the world, not being able to step into my own authenticity, led me to places and people and choices that, when I was in a relationship with somebody who was struggling with their own sort of HIV disease and what that meant for them and their own shame, I was often in a place where I had a choice. I could either survive the day and make choices that might have ramifications for 20 years from now, or I could have a house blow up in violence. And I chose consistently to get through my day, right? So I made choices that put my health and my well-being at risk down the line. And so it's no surprise. It was no surprise that when I tested positive. And I tested positive in 95, and I didn't have sort of the will. I was just diagnosed just prior to medication coming online. And so I rapidly got very sick. By the time I was diagnosed with an AIDS diagnosis in 2000, and I got to a point where 2001 going into 2002, I had 33 T cells in a viral load that was unmeasurable. It was off the charts. And I was going to die as far as anyone was concerned. I wasn't going to make it to 40, that was for sure. I was diagnosed with HIV at 28. And in 2002, I was sort of I was 34, approaching my 35th birthday, and I made a decision. I made a decision that I was going to transition because I would be damned if I was going to die a girl and die unhappy. And that was like that was the moment where I had made a decision that was purely for me. It was the first time that I had really truly stepped in and said, consequences be damned. I'm going to do this. And the truth is, I didn't think I would be alive to face the consequences of that choice. But lo and behold, as I made a choice to start taking testosterone and to claim an identity that since I was a little kid I knew to be true. And as I started to like myself, my T cells went up. My viral load started to come down a little bit. My ability to tolerate some of the pretty horrific side effects of medications, I had a future worth fighting for. And it's a critical piece to understand that I think that often, particularly medical providers, their window can be very narrow. And if I don't have a life worth fighting for, nothing you're going to sell me is going to make a difference, right? You're going to give me medication that's going to make me pretty sick. And if if the balance of that equation isn't worth enduring, why am I going to do it, right? Like, you know, and so my old age had to matter to me. And it did. Like, suddenly I was like, oh, like, if I can die a cranky old man driving around on the John Deere tractor, I'm good. Like, I can do this. And I started to show up. I was far more compliant with medication. I was far more compliant with doctor's appointments, and all around healthcare, like, you know, massage and acupuncture and all of the things that were offered, I could show up. But really the thing that mattered was that I was invested in me for the first time in my entire life, you know, and so I did, and you know, I was able to, I got my T cells over 200 for the very first time in 2004 as a way, I had to get to 200 in order to have chest surgery, and so I was like on a mission to find, like, you know, 170 some odd T cells from someone, and I did, you know, and you know, I was able to have chest surgery in 2004. And consistently, you know, like, this isn't an easy path, and particularly for long-term survivors, it's not easy, right? Like, it's that the illusion that this is easy, because the system doesn't actually collude with my survival. And I'm a white trans man. If you add in, you know, race and all kinds of other factors, then, you know, it's the system's more colluding with our annihilation than with our survival. But, you know, part of the thing that I think we encounter, as particularly as trans men and transmasculine folks, so being really mindful that trans folks exist on a really broad spectrum. And so I happen to have been somebody that was raised a girl. That didn't work for me. It wasn't an outfit that ever made sense. And so I packed my luggage and I moved to a new house. Like, that's how I describe it. I am partnered with someone who is also assigned female at birth, was raised a girl. That didn't work for him, but he does not identify as a man or a woman, so he sort of takes his luggage with him as far as I'm concerned and changes his outfit depending on the day. And so we exist in a multifaceted, complex world that often exists beyond language, certainly beyond dominant culture's language. And so when we talk about men and women, understand that it's an incomplete and false binary. And we know particularly from the national surveys, not just from ours, but from the survey from NCTE, the National Center for Transgender Equality, that non-binary folks are even far more at risk in many ways, particularly non-binary folks of color. And so understanding that kind of stuff. And so what often happens, particularly for transmasculine folks, is that if you see me, and I walk in, and it happened, I walked into an AIDS service organization. I had just relocated to a major city from a relatively small town, and I walked in to get services, and I was overwhelmed. I'm not a city kid, and I was just completely at a loss. And I walk in, and all of the forms, and this was only a few years ago, all of the forms that I saw didn't reflect who I was. And I sat down with a person to do intake, and he looked at me, and, you know, you can see from my picture what I look like. And he looked at me, and I used boyfriend to refer to my partner, and he immediately just crossed off he's like, well, we don't need to talk about pregnancy, and he moved on. And I hadn't disclosed my history. I hadn't disclosed my partner's history. And I took a deep breath, and, you know, and I was just meeting wall after wall, and for that moment, I found the courage and the sort of will to care, and said, you're missing a huge piece here. But I didn't quite feel like, I was like, mostly I didn't want this to happen to the next person that came along, and I had resources that day to kind of give a fuck about what I was going to do, right? Like, so I was like, you're missing something, and this isn't okay, and you've erased sort of a lot of you don't know what my anatomy looks like, and you certainly don't know what my childhood history was, and had I not actually been trans, but my partner pregnancy would be a problem, right? So we'd have to figure that out. And so, but what I felt when I just kind of gently said, hey, you're missing a big piece of this, and here's the deal, is he immediately got really rattled, right? And not terribly happy. And it's, not his fault, it's the agency's fault, and the forms are wrong. And so, but I never ever really connected with that agency. Like I never felt like, it didn't feel like they took that information and then really decided to change their culture. And so every interaction I had felt like I was swimming uphill, and I didn't have the energy for it, you know, and so I think that happens to a lot of us, right? And I think particularly for folks who, you know, testosterone changes a lot of us, and if we choose to take it, it changes a lot of us in ways that are not immediately pegged as somebody who wasn't raised a boy. And so I think there's a lot of things to really be mindful of. You know, I've seen people talk about, you know, I saw the questions about trust and about welcome, and I do a lot of work around radical welcome in faith spaces. And one of the things I tell people all the time is that there's 3 levels of welcome. And the first one is invitation, which is this level of I'm inviting them into my space, but my space isn't going to change, right? Like I'm inviting them, and they're expected to conform to the norms of my space. And the second level, which is slightly better, which is something called incorporation, which is that cultures meet and kind of honor each other. So I'm going to invite them into our space, and I'm going to learn about their culture and offer up what ours is, but neither culture is going to change. And it's workable. It's not great. And there's something called incarnation, which basically means that for radical welcome to happen, that spaces have to actually be willing to no longer exist the way that they are. And so I would say that it works in churches and congregations and in faith spaces, and I think it needs to work in medical and particularly aid service organizations and social space. When there's social space involved, like, is the space, like, you can't just invite people in and not look at the norms and not look at who has power and who is holding the meetings and who's on staff. And so inviting people in is one thing, but is the culture willing to completely transform and understand that those who have been brought into that space bring knowledge and wisdom? You know, and trans folks have a way of looking at the world that is outside of dominant culture's eyes, right? Dominant culture, and, you know, particularly the sort of white patriarchal culture that we live in this culture, in the U.S. especially, is a very particular framework. And when you have had to navigate outside and look at a lot of the hypocrisy, we come in with a level of, you know, like, hey, none of this is working, and it's not working for you any more than it's not working for me, and what are we willing to give up? And I think that's a big piece of why invitation to consumer advisory boards and invitations into spaces fails miserably is because culture is not willing to change, right? Like, the people who have had power in aid service organizations for the last 20 years aren't willing to actually give up power, and aren't willing to be profoundly uncomfortable. And in order for us to actually begin to service the people and to service people well, we need to, as folks who have power and access, we have to really be willing and find the resources and the abilities to be profoundly uncomfortable with our not knowing. So I think that's a big part of where we get stuck, is we get addicted to our own competence and we're not willing to be vulnerable and to sort of not know. And so I think that's sort of a big piece of the challenge on the table. You know, and you know, I really truly believe that shared liberation and you know, flows through everything that we do. And so if you know, that sort of moving beyond a savior complex to realize that when we actually start to serve as trans folks, you know, and all of the folks who are sort of radically marginalized, you know, that's when we end the epidemic, right? That's when we find a cure, and that's when. But it's not going to be from places of ease and places of not having to stretch, and not having to actually radically change the ways that we think and deliver service. So I'll stop there. Wow.
Gio, that is an extraordinary story. Thank you so much for sharing. You know, lots of comments in the chat room echoing, you know, that sentiment that, you know, just amazing. I'm really caught up on some of the ways that you were talking about welcome and invitation and culture, and I'm wondering if there are any resources that you can share with us, any links or any documents or any tutorials or courses that you've found helpful, because there's a lot of conversation within the chat room about how we help the provider community to get over themselves, get over that savior complex, get away from using those binaries, take their blinders off. You know, anything that you would suggest?
I think that's a part of that because, I mean, a lot of the stuff that myself and a few of us do is that sort of, we do it in faith spaces, you know, and it's always applicable because really what we're talking about is undermining dominant culture, you know, and dominant culture in, you know, the pillars of sort of, right, our current culture is certainly the medical establishment, right, faith spaces, like corporate spaces. And so I can certainly definitely go looking for stuff. We might have to sort of piece it together. I haven't seen this language necessarily used in medical settings and service delivery, but we can find it.
Awesome. Nishi made a comment just now in the chat room that I really love, and it's thinking about this in terms of collaborative work. And are there opportunities to build on the types of inclusion and team building that we already have working in some of our states to see if we can advance this ball and to, you know, push ourselves further to get uncomfortable and to start having these discussions that will challenge the culture.
Right.
Great. So, Tio, thank you so much. I'm sure that people will have questions and there'll be more, you know, dialogue with you later on. But
absolutely.
Judy, I think that we have another speaker who's ready to speak.
Yes, we do, and we Nala Toussaint, and Nala Toussaint is the prevention coordinator for the transgender services at Callan Lord, which is a community health center in New York City, where she works with trans women to support their health and well-being. Nala has done extensive work as an outreach liaison, conducting safe sex intervention activities for youth and coordinating educational and job development services at renowned LGBT public service organizations. Building on her educational success, she plans to pursue a master's degree in social work and business, and we're very pleased to have her. Thank you, Nala.
Thank you for having me. Can you all hear me?
Yes, ma'am.
Awesome. All right. So, yeah, I started at Callan Lord as a PrEP specialist in March 2015 and contributed to over 1,800 patients accessing PrEP, and then promoted to prevention coordinator. So kind of the information I'm going to share is more so of the experience in which I had. Currently, I'm working with the Me, Myself, and I program, which is geared for TGNC folks of color ages 16 to 29. So we at Callan Lord are focused on creating a safe space. So therefore, if a patient comes in, they feel comfortable with our staff and agency, and we encourage our patients to open up and to be honest about their experiences. And through this, we're able to train our staff. Once a patient is able to say, hey, this is how I'm feeling, this is what I'm experiencing, so the information that we then receive can then go to our staff to better the healthcare system and foster a safe space. So what we've learned is that when you acknowledge and validate and try to address the social and economical and cultural barriers that present themselves, you have a higher risk, a success rate, to gain trust from the community. And this is an important piece because oftentimes we have a patient and we say, we're going to give this patient this thing, and then the patient comes in with a lot of different things, right? The intersectionality of either being homeless, right? You know, HIV positive. It looks a lot of different ways. So you never know what you're going to get. So it's really about listening to the patient when they first come in. TGNC folks, especially of color, are still a part of marginalized communities and deal with life-threatening issues such as racism, homophobia, transphobia, and this also shows up internally, you know, hypermasculinity, violence, and police brutality on a daily basis. So it's been a difficulty trying to get individuals to adhere to treatment, whether it be PrEP as a treatment, whether it be viral suppression as a treatment, right, retention, when they're dealing with all these pressing life issues. You know, we continue to take these issues in account when attempting to serve our community. It is important that we, the healthcare system, continue building safety and solidarity. So what has worked? Let's talk about that. Simple. use preferred pronouns when a patient is coming in. You don't understand how much the way we identify is so important to a patient, how they're going to receive you. So we've come up with this pronouns matter where when folks come in who identify TGNC or just any folks, they're able to write their preferred gender pronouns on stickers. So if a nurse meets with them or a provider or just a PCA, which is a front desk person, we know what pronouns they go by, or she goes by, or he, or they, or they, and the list goes on. You understand? So it's also not to make assumptions about sexual orientation and or gender identity. Remember, identity is different from behavior, right? So considering using terms like front parts or back parts for genitalia. Train all your staff about LGBTQ inclusion. So what we have is our front desk train, customer service, security guard, contractor staff. Those are all important, right? Establish gender-neutral bathrooms. Display posters and educational materials representing diverse individuals. Differentiating between gender and sex assigned at birth on patient form. That's a huge thing. The minute that a patient comes in and filling out information, those can be triggers for a patient, especially TGNC folks, when they're reading assessments that doesn't include who they are. Collect data relating to LGBTQ patients and their health. You know, currently we still have, trans women being included in MSN studies, and it makes it difficult for us to really get knowledge about the requests and the needs that we have, and also we're lacking trans men being included in data, and especially when it comes to retention, when it comes to PrEP, the list goes on and on, So how do we do this? Counseling approaches, so sex neutral, sex is inherently neutral thing, so it's not a good or a bad except for how we experience it. That's the important part. Clinical and non-clinical staff must be comfortable to discuss sex and drug use in depth. So, having a non-judgmental attitude during counseling, affirming current methods of risk reduction, reflect patients' language. That's important. You want to get a hear of what you're hearing from your patient, where they've come from, what they experience, affirming that, and guiding them to where they want to go. So again, back to the screening and assessment, right? Questions like, what brings you in today? What gender do you consider yourself to be? What is your sexual orientation? What gender are your partners, right? What kind of sex do you have? Oral, anal, vaginal, top, bottom, both? Because remember, we're talking about a language that is broadened between LGBT, right? Front, back parts, Where and how do you meet your partners? Because that gets a sense of where they experience, where they're located. Are they in clubs? Are they meeting them online apps? How have you been tested for HIV before? When was the last time you were tested? Is there anything that happened recently that worries you in regarding to HIV status? Do you use drugs, alcohol? How do you feel about drug or alcohol use, right? What are some ways that protect yourself against HIV? Also, questions around PrEP. Do you know about PrEP? Tell me about what you've heard. And these questions allow us to see, okay, how can we assess this patient on the need? Because sometimes there are, again, bigger issues where we may have to refer folks to mental health and different programs, ICC, intensive care, coordination, things of that nature. So in terms of reframing questions in sexual health, instead of, again, asking how many people you have sex with, you want to try, can you tell me about how many partners you have since the last time you were tested? And remember, when we say tested, it's not just about HIV. Also, we have to acknowledge that hepatitis C is on the rise. We want to give patients a full body experience of health care, especially TGNC folks, and also give them the space to have an estimated idea. instead of asking questions, do you have receptive or anal sex? Try what parts, again, do you use? And lastly, before I end and pass it over, hiring trans-identified staff is so important, and investing in those staffs, right? It's important, that we provide health care to TD&C community, and making sure that when we're having these discussions, they're at the table. That shifts the way in which we receive things, and especially folks of color, TD&C folks of color, and putting them in managerial roles is important because you see, starting from one point and what they're now doing for their community. So I'll end on that note, and if any questions arise, I'll definitely answer.
Great. Thanks so much, Nala. There is quite a bit of activity in the chat room, and I'm conscious of time. We have half an hour remaining on today's call and a couple more topics. So I want to just kind of raise for people to think about the themes that were in Nala's talk, were some of the issues around trauma-informed care, thinking about, reflecting back on what Tio and Cecilia had mentioned about, thinking about people and where they're at and what their needs are and what their priorities are, instead of thinking about, as a medical provider that I have to meet X objective, and forgetting about the person in front of you. So, those are just some of the things that I mentioned, and we'll have more conversation and ability to talk about all this once we hear from Milo. And Milo, I'm going to try to unmute you right now. Did I get the right line?
Yep, can everyone hear me?
Yes, and Judy, can you introduce Milo for us?
Absolutely. Milo is from the Howard Brown Healthcare Institute in Chicago, and he is a Ryan White Part D case manager. He works with trans and cis women of any age and male-identified youth under 25 living with HIV to support them in managing their medical care, connecting to resources, and working towards self-managed care. Milo plans to pursue a career in health law to continue his work as a trans health advocate. Milo?
Great, thank you. Thank you. So I do Ryan White Part D case management, and about half of my caseload is trans women. Most of those folks are of color, living with HIV. So as a medical case manager, my focus is on helping folks engage with HIV care, but much of my time is spent working with clients to access trans health. Like Cecilia mentioned earlier, that tends to be a major priority for folks. So I'm just going to share an anecdote about a patient experience that shows examples of kind of what I see in my experience as the three major kind of categories of barriers that get in the way of trans health. So those are access to competent and affirming providers, access to accurate information about health and about trans health in particular, and then lastly, financial accessibility or access to resources, so everything from insurance to hormone prescriptions. And then we know, as other speakers have mentioned, that those barriers are even more pronounced when you start working in other factors like living with HIV, dealing with systemic racism in the medical field, classism, poverty, homelessness, et cetera. So the patient, I'm going to share her story. We'll call her Catherine for today. So Catherine is a Black trans woman in her mid-30s. She recently had vaginoplasty about 6 months ago with a surgeon in Miami. She'd been working with the surgeon for many years, sending him money in installments, scheduling several different surgery dates, and then canceling due to not having the money in time that she thought that she would. But she finally, 6 months ago, paid in full and was able to set a date. So she had the surgery, but about 2 weeks before surgery, and this was about a week before the patient was due to travel to Miami, the surgeon called to inform her that she needed 1 and possibly 2 therapy letters before he would perform the surgery. So he actually already had a letter from the therapist on file from the last time that Catherine had set a date, which was about a year prior, but it turned out that that letter had expired. And so the surgeon now is telling her he needs 1 and possibly 2 more letters. So he neglected to tell her that the former letter had expired until 2 weeks before the surgery date. So Catherine called me, was pretty upset, felt like he was being unclear with her on the phone about why she needed the extra letter, whether it was 1 or 2, how to go about doing it. She didn't have a regular therapist that she was seeing at the time to ask to write a letter for her, didn't know how to find one. and that's a service that Howard Brown currently does not offer for patients who are not already seeing a therapist regularly. So what we do have is a list of external referrals to refer people out. So I ended up calling several therapists on the list to find someone who would be willing to see her on such short notice and who could offer sliding scale services because the patient had Medicare, but none of the providers on that list accepted Medicare for their therapy services. So I finally did find someone who was willing to see her on short notice. The therapist was great, ended up writing her the letter, and the surgeon accepted it. And then after a very lengthy conversation and argument with our site medical director between her and the surgeon about the correct WPATH standards, the surgeon ended up agreeing to accept just the one letter instead of requiring her to get a second one. So the patient ended up having surgery, and then afterwards came back to the clinic many times over the 6 months following her surgery to get follow-up care. So she had some open wounds left by the surgeon. She was sent home back to Chicago with a catheter still left in and no follow-up instructions for how to go about removing that or when to have it removed. And then the surgeon and his office were generally pretty dismissive of the patient calling to ask follow-up questions about post-op care. And she also shared with me when I met with her that she had experienced a great deal of racist treatment from the surgeon and had watched him and his office staff treat her noticeably very different from white clients that were sharing the lobby space with her. So at this point, Catherine is fully healed, ultimately very happy with the results, but the experience as a whole was incredibly draining for her, and she described it as taking a very large toll on her mental health. So just to get back to those kind of main barriers to care I was talking about, so the number one barrier I mentioned was access to affirming competent providers. So this surgeon is not someone who falls into that category, in my opinion. So Catherine saw this surgeon, and he insisted on using outdated standards to assess her mental fitness for surgery. He did a bad job on the actual surgery, and in addition provided incredibly inadequate follow-up care and instructions, not to mention demonstrating racist attitudes and just generally not treating her like a human being throughout the course of her work with him. So we know that finding a medical provider with trans health knowledge and competency can be very challenging for folks, and I'm fortunate enough to work at a place where we have providers who are committed to providing affirming competent care, worked really hard to create a safe space that's affirming for trans clients where people feel comfortable coming in, being honest about their experiences and their goals. And the providers here really make an effort to learn from trans patients as well, to value the trans health knowledge and community trans health knowledge that trans folks have. So some things that we've done to kind of support that effort to make the space to support, provider competence are, hiring trans staff first and foremost, as Nala mentioned. That's incredibly important. Doing trans trainings, or kind of Trans 101, but also more in-depth. There's specific trainings on things like hormone dosing protocol for providers, basics of document change processes for case managers, and really just working on building an employee culture of prioritizing trans health. So Catherine was ultimately comfortable coming here for aftercare when she was not comfortable calling her surgeon's office to ask questions. She got the care she needed from her medical provider, from myself, and from some nurses who she saw as well for follow-up wound care. And she ended up beginning therapy as a result of the whole process, which she's still engaged in and is going very well. So I personally was able to support in that just by listening, validating her experiences of really negative treatment by this surgeon, and then stepping in and talking directly with his office at the point where she was no longer comfortable speaking with him. So kind of the next major barrier then is access to accurate information. So processes for obtaining transition-related care are often very confusing and unclear. So for example, different clinics and different providers have different guidelines for hormone administration, different processes for accessing hormones that are often not well publicized and confusing and difficult for patients to navigate. Insurance coverage for hormones and surgeries is very confusing, differs state by state, as are name and gender marker change processes, which, again, confusing, different state by state, hard to find accurate information. And, also trans people, I think, get a lot of trans health knowledge from personal experience and also sharing experiences with other trans people. So being able to provide accurate information is not just helpful on an individual basis. I also view it as kind of a public health strategy, in particular for this community. So Catherine had spent about 10 years working on arranging the surgery and ended up paying out of pocket and traveling to Miami. And because of a lot of confusion and constant changing around surgery coverage guidelines with insurance, and because of how far in advance she had been planning the surgery, she was unaware that there are, in fact, some surgeons who will accept Medicare to cover the procedure that she underwent, albeit often with long wait lists. So the surgeon that she saw suggested to her that she come back for a revision with him and offered her a discount to come back and see him again. And before speaking with me about it, she was under the impression that that's kind of her only option, her cheapest option, when in actuality, there is a surgeon in Chicago who accepts Medicare and can do the revision and charge her insurance company for it instead. And then the surgeon also gave her really inadequate information about follow-up care, and she had to come and seek it out from her primary care office. So she was not able to access that information that she needed, that very crucial healing information, directly from her surgeon. So some kind of resources and strategies for improving that access to accurate information. Again, hire trans staff who can relate to trans patients who understand their experiences and can kind of create a comfortable space for people to be able to share openly. Require that providers working with trans patients kind of have a working knowledge of trans health in terms of terminology, as Nala was speaking about, in terms of insurance coverage guidelines and practices in their state, and provide educational materials with information for patients about how to navigate these systems and about processes for document changes and things like that. So I was able to kind of support in that realm by working with Catherine's primary care provider to ensure that she was being given accurate post-op care information through her primary care office. So and then kind of the last piece, the major barrier that she faced was access to resources and the financial accessibility of services. So that's a major issue for all aspects of trans health and health in general. So everything is expensive: hormones, needles, surgery, document changes, clothes, transportation, food, hygiene products. And trans people, particularly trans folks of color, we know experience high rates of financial instability and poverty. So, making trans care financially accessible also has to be a major priority. So Catherine really ran into this barrier at every turn, everything from paying for surgery itself, which, as I mentioned, took her over 10 years to finally get there, to travel costs to Miami, to the last-minute therapy letter, which would have been around $500, and she now found a therapist willing to do it on a sliding scale, and then even just transportation to and from aftercare appointments and, cost of dilators. So some things that Howard Brown does to kind of bridge that financial gap we have a 340B program at our partner pharmacy, which helps people access hormones at a discounted rate. We offer a drop-in night twice a month for trans and gender nonconforming clients to see a medical provider, have a free meal, can access some free hygiene supplies and bus cards, as well as a clothing swap and a needle exchange that just started that I'm really excited about. And then, just creatively utilizing resources in your state. So, for example, Illinois ADAP does cover hormones. So for folks living with HIV, that's a way to get free hormones by utilizing ADAP funds. So I was kind of able to support Catherine in that by helping her find ways of reducing the cost of that therapy letter and then offering transit to and from her post-op care appointments, which she would not have been able to make it back and forth from without bus cards. So I guess kind of my main takeaways are there are definitely things as service providers that we can all do to reduce trans people's barriers to care, like addressing issues of provider competency, making sure that we're knowledgeable about trans health and kind of disseminating accurate information to patients, and creatively utilizing resources to help reduce or eliminate the cost of services. But I also think that there are limits to that work, and in order to be an effective provider, you also need to be a patient advocate and kind of take the lead from patients in that role. So for this particular client, her surgery, to her, was her biggest barrier to living a full and healthy life. So she works with me as a case manager for her HIV care, technically, but we almost never talk about or do work around HIV care specifically because this is her kind of health priority, and her feeling whole and complete and addressing her trans health concerns is what really helps her stay on top of her antiretroviral treatment. So my role was to support her in what she felt was the most important aspect of her health, and that in turn has really helped her keep her viral load down. I think all in all, be a patient advocate, hire trans staff at your organization, especially trans people of color. Make sure that your organization reflects the populations that you serve. You know, Catherine, when she was interacting with the surgeon at his office, no one there, she felt like no one there understood her or respected her as a human being, and she experienced this as a trans woman of color in terms of both transphobia and racism. So it's super important to invest in trans staff in front desk positions and places of visibility, but also in positions of leadership to kind of help make cultural changes in organizations. And so, we know our healthcare system is not designed to work for trans people, so advocating for structural change wherever possible is key. Like the medical director here at Howard Brown getting on the phone with Catherine's surgeon and telling him, you will accept just one therapy letter. You are not going to put this patient through the extra trauma of having to go and find and pay for a second therapy letter within a week of surgery, advocating that he use the correct standards for trans health rather than incredibly outdated ones. And I think especially in light of tomorrow's inauguration, I really want to just encourage everyone to leverage physicians as healthcare providers to advocate not just for your patients on an individual level, but also for structural changes to improve healthcare access for trans folks in general. I will leave it there.
Fabulous. Thank you so much, Milo. And I am looking at the clock. We only have about 15 minutes left. So I just want to emphasize, the power of these stories. We've heard a lot from the stories and examples shared by each of the speakers that illustrates the opportunities in front of us and some of the solutions that we can explore. There's a lot of conversation in the chat room around some of the solutions that you'd mentioned, Milo. And I'm just for Milo and Nala both, maybe we can have a conversation after today's call with so little time remaining left in the call around what types of resources you have available, if you have policy and procedures that you'd be willing to share, if there's any scripts that you use when trying to train your staff, around pronoun use and in just helping to be affirmative for working with trans folks. That would be really appreciated. So Cecilia, I know that you had wanted to just bring attention to the video library for Positively Trans, and I think that we can spend about 30 to 45 seconds previewing this one. Is that good in your book? And Cecilia, you may be on mute, so let me unmute you. All right, unmuted. So Cecilia, I don't know if you want to provide any context.
So this is one of the videos that I shared with Michael, and some of these videos are not posted yet apparently, and some that you could find on our website came from the workshop that we did in Atlanta with some transgender women, and we created a workshop 3 days. They wrote the script, they collect images, and also, it's in their own voice that they put this video together. So this is one way to build some additional skills for them, especially, social media. Everybody loves to see videos, and this is just another way for us to help build leadership in a more non-traditional way, so to speak. And, they learn to deliver the stories in 3 minutes or less.
Wonderful. So let's take a quick look at the beginning of this one to get a sense. And of course, I'm having a challenge with sound. Yeah. So I don't want to take up time when we can't hear the sound. But this is a wonderful, opportunity for folks. I think that that's an excellent point, Cecilia, that by letting people tell their stories in this medium, you're giving them the power to share and also, empowering others. I think it's wonderful. A number of folks are mentioning in the chat room now that they would like the links to these, so we'll definitely provide that. And All right, so we'll come back to our presentation. And the next thing we were going to talk about, Cecilia, was the National HIV/AIDS Strategy Transgender Health Indicator. Take it away.
The National HIV Strategy has been released for 2 years now, and it's not until World AIDS Days last year that we were able to came up with a what we call indicator, to look at the performance of transgender healthcare in the National HIV Strategy. And because there are different ways of collecting data, and also between CDC and HRSA, that because it's not necessarily unified, we had to find the most consistent source of data collections that we could actually compare. And so after much review, we wrote out the indicator, which is, on viral suppression, because, HRSA is ahead of so many different, health systems that they actually have been collecting data around, transgender people living with HIV for much longer than, any other systems that we could find. And so that would be the indicators that we are going to use as we move forward. As I mentioned earlier, that really goes back to why it's important for us to connect some of the gap analysis with those who are not virally suppressed, and to see where some of these intersection is. And that's where when we look at all the different social determinants, they're more likely to be in poverty, they're more likely to be uninsured, they're more likely to be people of color, and they are very likely to be living in the South, in a state where there's no expansion. So that helps guide, some of the work as we move forward, and also, to really be able to talk about, when we look at creating new programs, where we should prioritize. And one other point to make that's connected with the National HIV Strategy, it's about retention and care. So currently, HRSA has a grant, that will be wrapping up next year. It's called the Special Project of National Significance, where they have funded, about 9 different sites, to provide HIV care to transgender women of color living with HIV. So we will get some data from them, beginning next year, to see what if they could actually create a new evidence-based model of care provision. So a lot of exciting things are happening, and this is a very interesting time, to be, part of this transitions, and hopefully we would have enough data to show and make the argument necessarily why, being insured is so important, and why, Affordable Care Act plays such a huge part in the National HIV Strategy.
Wonderful. It is a very exciting time. I'll agree with you there. I'm so inspired by the stories today, and, just by your spirit, Cecilia, and, yours too, Tio and Milo and Nala, in terms of helping to ensure that, we have health equity in our programs. I think that it's just phenomenal. Now, noticing the time, we only have 7 minutes to go, so I'm going to quickly give you a sneak preview of upcoming stuff before we have a conversation. So what I want to see or let you know is that we have Partners in Care discussions coming up the last Thursday of every month. So next Thursday, we're going to be talking about transgender health again, and we invite transgender people living with HIV and the allies to join the discussion. Cecilia and Tio are going to be walking us through more of these elements of being part of the care system and empowerment and increasing leadership skills and finding a voice. So building off a lot of what we were talking about today. And you can see that in the following months we have discussions that will, you know, address other groups that we're working with through this initiative. Today is our Transgender Health webinar, and you'll see that the third Thursday of every month we're focusing on a topic that is very similar to what we did here today, so MSM of color next month, and so on and so forth. We have some exciting office hours opportunities coming up. We're focusing a lot on stigma. Stigma is one of the greatest barriers that we face, and there's a lot of work happening in the field right now to help us advance this ball. So we're having a provider focus group February 17th and a consumer focus group on February 24th to think about MSM of color stigma. But as everyone has mentioned, there's great overlap and intersectionality of these different groups, and you can be a trans Latina woman who is 22 years old and you fit 3 of these different groups. We invite everyone to join these focus groups, you know, as a provider or consumer, to think about stigma and what we can do to address stigma in our services and in our own communities. So, Judy, we have 5 minutes left for question and answer. I don't know how you want to address this.
Well, I think that we've covered quite a bit just in the presentations themselves, but I know there's some questions in the chat room that you may want to travel back to, and on the floor if anyone else has not had their question responded to that you want to bring up, you can ask to be unmuted and pose a question at this point.
Absolutely. I'm going to go ahead and unmute Alicia Rubenstein, who's had some fabulous questions throughout today's presentation. Alicia, I don't know if the limited time remaining, if you want to pick one of your questions to ask live and to see if we can get a conversation going around that.
Oh, wow. I guess I did. This was really inspiring and it evoked a lot. I guess that I had concerns with the gaps in care of how we're addressing our gender nonconforming members, and then also like making information all available so that, you know, if we have like the provider deserts. I think that was an issue too, like how do we deal with that and people having to wait for services and that being a barrier.
Yeah, so any of the speakers can address that question. I heard, you know, each of you addressed this to a certain extent, both questions. So, you know, I don't know who wants to start first.
I'll just put in a, can everyone hear me?
Yes.
Yeah, okay, so I'll just put in a plug for a resource that I just added into the chat room called Rad Remedy in terms of kind of provider desert and helping people find competent providers. It's a really great resource where patients can go and add new providers that aren't in network or write reviews about providers just to kind of let other folks know who to go to. It's pretty extensive. It has primary care providers, surgeons, mental health professionals. It's a good way to find providers in areas that are, especially like non-urban areas where it's more difficult to find providers or hubs of places that are working insurance.
So this is Cecilia. Some of the other discussion has been going on right now in terms of providers, deserts, and how to address that is like we can't force people to become culturally competent. It has to come from, you know, a place of either, you know, like a requirement or, you know, like, or they really want to do it. So so instead of trying to risk, you know, community members going to, you know, like hostile or, you know, like providers who might not be as sensitive to like trans and gender nonconforming people's needs. We are also looking at exploring and, you know, advocating, you know, that as, you know, a resource is with today's technology, you know, like all these like telemedicine, it becomes like available. So we have like these conversations, especially for rural areas where they have like even fewer providers than, you know, major cities, that using telemedicine might be a good way to bridge that gap.
Beautiful. You know, and just as a sneak preview, we saw that in the upcoming announcements, our topic for the month of May is African American and Latina women. And one of Cecilia's colleagues, Ariana Lind, who is based in Broward County, I think, down in Florida, is going to be sharing some of her work that she's done around telemedicine, which has been really important and life-saving for trans folks and other, you know, disempowered, disenfranchised groups out there. So a plug for our March webinar. Okay, it is now time for us to say goodbye, unfortunately, but a couple of things to look for. You'll receive an email later today that includes a copy of the recording and a copy of the slides. I'll be in discussion with Milo and Nala to talk about some of the resources that are provided or available at Howard Brown and Callen Lorde, respectively. I'll be making sure that you all can see the Positively Trans videos that Cecilia has shared in the chat room. And also, you know, I'll talk to Tio more about his invitation matrix because there are quite a few light bulbs going off when he was talking about that earlier as well. So be on the lookout. Later today, you'll receive an email with lots of goodies. In the meantime, thank you so much for joining us today, and I hope you have a wonderful day.
Thanks, Michael. It's been great.
Thank you. Thank you. Bye-bye.